This conference will now be recorded.
So in the last class, we were trying to understand that the misclassification of the drugs creates a problem and how pharmacoepidemiology helps in order to address such issues. Where in misclassification, we have already seen two groups where the drugs are teratogenic, but they are not identified, or where the drugs are given which are considered to be teratogenic but not consumed. And the third type, which we are going to understand today, is misclassification of gestational timing of exposure. Gestational timing of exposure. Now, so the gestational time, let us understand the meaning behind this. Sherin Babu, what is gestational timing?
Yes, sir. Gestational means during pregnancy time.
Correct. So it is the duration of pregnancy or the time during the pregnancy period is called as gestational timing. Now, if you see the different phases of gestational uh, timing, there are phases where cells start differentiating and the organs start developing, and they fully develop as the gestation period increases towards the parturition process. Now, the question comes, when the medicines are administered, that is where the problem is going to be seen. See, medication administered before organ development, say, let's say, first trimester, during first trimester, and the early phases of the second trimester, where the organs are going to develop and lead to the further growth. So if the drug is administered at this particular time, there is a more chances that birth defect will be produced. Birth defect will be produced. ಗುಂಪಿನ ಅದೇ ಆ ಥರ ಪಿನ್ ಇಲ್ಲ ಗುಂಪಿನ ಇಲ್ಲ 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 ಇದನ್ನ ನೋಡಿ ಟ್ರಾನ್ಸ್ಕ್ರಿಪ್ಷನ್. So birth defect will happen if the drug is likely to have teratogenic effect. If the effect is not produced, so there is likely that birth defect may not be produced. See, if you carefully observe high risk teratogenic drugs, moderate teratogenic drugs, the percentage varies from 0.1 to 25%. Moderate risk teratogens can produce the birth defect from 0.1 to 1. That means to say that remaining 99 people will not experience the birth defect, right? So even though the medications having the risk of teratogenic is administered, there is a chance that birth defect do produce, which we are very clear, and birth defect may not be produced also. This possibility is also there. The second phase is that when the medications are administered after the organ development. Now, probably what they say is that the birth defect will not be produced probably, but there is a chance that respiratory depression, cardiovascular depression are likely to be the chances once the organ development has taken place and you're trying to administer drug. Remember that also. Because morphine, when you administer at high doses, not only it causes the depression of the mother respiration rate, but it also causes the respiratory depression of fetus which is growing. So when fetus respiration rate comes down, then there is a chances that fetus may die. But birth defect is not there. But here, the organ which is developed can work at low pace or at high pace under the influence of the drug. Okay, so you need to be very careful what is that we are trying to understand. On one side, we say that there's a definite birth defect where there will be a loss of limbs, loss of neuronal development, loss of incomplete development of the face and other organs. That is one thing which is visually seen. But there is a total effect that can be produced on the fetus if the drug is given at the last trimester. It may not be birth defect, but it is a definitely a kind of birth, distress. So where the chances of fetus undergoing difficulty is always there. That is why you need to classify the drugs as those drugs which causes the birth defect and those causes which the distress to the growing fetus or grown fetus, right? So misclassification of drug exposure timing cannot give us indication about the teratogenic activity. And here, pharmacoepidemiology concept is very useful in order to classify those drugs which were given at the first trimester, second trimester, and led to birth defect. Those drugs which are given the trimester and no birth defect is produced. So pharmacoepidemiology helps to assess this, the timing of medication administration during the gestational period, right? So that is the misclassification of the gestational period. You have one more clinical issue under misclassification is that recall bias, what is known as recall bias. Now, in this recall bias, what happens is that usually it is the mother is asked the question. I mean, using a questionnaire, the mother will be asked the questionnaire, and the ability of them to recall what happened that is going to be assessed. Usually, this is done with the assessment of case control study design, right? Where patient is also there and control patients are also there. So case control approach is going to be used commonly in assessing the birth defect in order to classify drug-induced birth defect. Now, when we do that, what happens? You see, the woman who has given the birth for a child which is normal, that will be control, and this woman and another group of women who has given birth to the child with defect, right? One woman with child with no birth defect. Another group, woman with child with birth defect. Both will be interviewed using the specific question, or they'll be interviewed verbally or using the question. When they are introduced, when they are interviewed or a questionnaire is administered, when did they take the drug? When did they take the drug? And whether the defective birth is because of that. Here, the questionnaire is asked after the childbirth. Remember that. And in order to make the woman to recall or mother to recall whether the mother with whether the mother can say that the child with birth defect is because of the drug or not because of the normal birth because of the drug. You believe it or not, the recall of the drug use by mother with defective birth is more when compared to woman with normal birth, normal child birth with a normal status, clinical status. Now, this is a kind of bias known as recall bias. Woman in anxiety will try to say that yes, it is because of the drug only my child has got the defect, which may not be true, but because of the biasness, and they try to equate that with the drug use, and now the data which we are going to get is called as recall bias data. Now, pharmacoepidemiology helps in order to eliminate such kind of biased information. That is by asking specific question. When you ask a specific questionnaire, what happens is that if the mother is confident, then she can tell the answer. If the mother is not confident, then this questionnaire will automatically yield or give less scores, which indicates that the probability of drug causing birth defect will be low. Say, for example, I'll give you a simple example how this specific questionnaire can be operated. If the mother is asked whether the birth defect is because of the drug, she will say yes. Can you mention what is the probable date on which you have taken the drug? Unless they have a bill for having purchased, or unless they have documented the medicine administration, they cannot answer this question. So by asking specific questions, one can easily find out whether the mother is trying to give a answer or the data out of anxiousness or a real data. This is where the pharmacoepidemiology helps. Next thing is that comprehensive questionnaire. Instead of a specific questionnaire where the patient may be embarrassed and may get demotivated sometimes, what they do is that they go for the comprehensive questionnaire where they try to understand overall pattern, what all the things, consequences which the pregnant woman may face during her period, and try to make a conclusion out of it. but purpose is same thing, whether she is trying to tell the real data or not. That is, the purpose is same, but the way you put the question is completely different. So here also asking specific interview, like verbally. I mean, after the parturition, they will be there in the hospital, say for 2 to 3 days time, or maybe 1 week time. So at that time, they're going to interview, oh, what is this happened and why it has happened? Why do you think that this can be there? So such kind of specific questions can be put face to face. And also they try to understand the perception of women about the teratogenic effect of the drug. See, the perception of the common people about such effect will be vague or not specific. Sometimes they don't know. So what happens? Perception keep on differing from patient to patient. If you if the woman has a perception, yes, it is likely to produce, then her answers will be very much, very much biased. If the perception, if there is no perception, if the perception is weak, only if there is a real evidence, then only the answers will come out. Otherwise, it won't come out. So understanding about the perceptions of women about a teratogenic effect of the drugs also can give a real, real data about the teratogenic effect of the drug. So this is where the pharmacoepidemiology helps in documenting the drug-induced birth defect and also eliminating recall biased data. Right? Are you clear? Can we move on to the next part of it?
Yes, sir.
Yeah. Next clinical situation which we may come across is outcome based and how pharmacoepidemiology helps. See, outcome, like or we have seen that drug is always we tried understanding that okay, you assess the drug and assess the birth defect and try to equate it. Now in outcome, exactly they try to understand why this birth defect happened, why this birth defect happened, what is the reason, at what stage drug caused the changes or interfered in the growth of embryo. So based on this outcome, the concept is established. Then they can come to a conclusion that okay, because of this reasons, the outcome is like this, and the evidence become very strong. To give an example, isotretinoin inhibits the migration of or development of neural crest cells of embryo. Neural crest cells of embryo. Now, because of this interference in the migration, what happens? There may be a malformations in the face. The patient may lose ears, or heart may appear outside instead of inside. Heart chambers will be less, or the patent of pulmonary artery and aorta will not be separate. Neuronal tube, fallopian tube, especially in females, may not have developed, or the eustachian tube within between ear and mouth will not be developed properly. So what happens is that these are the malformations of certain organs definitely occurring with the isotretinoin drug, just because it has inhibited the movement or development of neural crest cells. Now, the research is developing in such a manner that the drugs are getting classified based on the mechanism of action. Those drugs that inhibit, say for example, are interfering in the development of neural crest cells, A, B, C, D, even the birth defect. Also, they are going to group birth defect type, malformations of face, malformations of ear, malformations of heart, and why this is happening. That is also they are going to relate it. At what stage of embryonic growth the interference happened or a defect happened so that it has led to the malformation of face or ear or the heart. So the research is trying to understand the birth defect from 2 points. One from the clinical point. At what stage of embryonic growth the problem occurred and why that has led to a certain definite malformations or birth defect. The second thing is that the drug, at what stage the drug has inhibited so that birth defect happened. So this clearly helps to understand the drug-induced birth defect. Now, pharmacoepidemiology helps in understanding the various drugs that are administered and the birth defect that is followed over a large population, whether it is really due to clinical effect or whether it is really due to drug-induced effect or mixture of both also, right? So that is the outcome. So here the concept is that the clinical issue, the birth defect and drug-induced birth defect is assessed at the level of the malformations of the organs. That is the outcome-based assessment. Next one is confounding issues and how the pharmacoepidemiology helps to address that. Say confounding. What is the meaning of confounding? Let us understand first. Aparna, Aparna,
Yes, sir.
what is confounding?
Confounding. Is it confusion?
Yeah, it is
Yeah.
like a confusion. Confounding means it is a confusion, a confused state. You really do not know why it has happened. So there are confounding factors also. Now, how the confounding factors will interfere is like this. See, we know that very clearly birth defect happens because of the drug. But really it is very difficult to say clinical condition leading to birth defect at that stage. You mean at the time of gestational period. It is easy to relate birth defect to drug because the mother has, the pregnant woman has taken the drug. There is a reason, but it is very difficult to find out the reason, the clinical condition leading to birth defect. So when birth defect happens, the confusion is that whether it is because of the drug or is it because of the clinical conditions or is it because of the drug taken to treat the clinical condition that has led? So these are the confounding factors that will sometimes confuse. Pharmacoepidemiology, there is no doubt that it can help to differentiate whether it is because of the drug or because of the uh, you know, something else. But the confounding variables, because of the clinical reason, can be dependent on these factors. Maternal age. If the pregnant woman is too young to go for pregnancy, that will have influence on the growth of the fetus. Or too old for the pregnancy also will have a problem. So the age factors, undeveloped or merely the less developed, causing the problem, maternal age. That is why pregnant woman should have the right age for the conception. Otherwise, the fetus is likely to suffer from malformation sometimes. Race. So racial differences also will influence. So for example, same race will have a same effect, but different races will have their own effect on the growing fetus because of genetic variations. So that may influence the birth defect. Geography also. So geographically, we are all exposed to different time, climate conditions, different weather conditions, different lifestyles, which is pertaining to the geography. So the growth and development of the fetus is extremely dependent on that. And socioeconomic status. We know that the socioeconomic status, if it is better, then the pregnant woman, uh, to have the nutrition requirement at the time of pregnancy will be good enough to give a birth to a child which is normal and healthy. Otherwise, some kind of defect or malformations may lead to the problem. Health behaviors. So if the pregnant woman is having a conscious about the health behavior, that is actually good. Otherwise, it leads to its own problem. Like for example, pregnant woman smoking will have a problem. Pregnant woman drinking alcohol will have a problem. Pregnant woman going for drug abuse will have a problem. Pregnant woman involving in substance abuse will have a problem. Pregnant woman will having a different sleeping patterns. Haphazard sleeping pattern will have an influence. So these factors definitely will have effect on the child. If not in the early stages, but in later stages, the child is likely to prone to such kind of characteristics. See, the medical reports always already proven that the children who are born for the mothers who are addict for smoking, alcohol, and other substances, their children will likely to have the same characteristics at the earliest age. So such an influence is there on the health behavior of the pregnant woman towards the child. So that is why one has to be careful. See here, you can see here 2419. There's some number. While reading, please do not consider it. Okay, just erase it out. Pregnancy termination. Here, what happens is that when the couple have the pregnancy and if they don't like it, they go for pregnancy termination. That will cause a lot of hormonal imbalances, and that may influence sometimes on the growth of the fetus when they go for the next time pregnancy. So it is a clinical situation that may cause the variation in the birth defect in future. So these are all the confounding variables, which is very difficult to prove, very difficult to have the evidence, but it may cause the influence. So pharmacoepidemiology helps to classify such kind of variations in the confounding variables when compared to its relationship with the drug, right? Any doubt in this? Can we move on to the next say part of it? Anybody has any doubt?
Yes, sir. No, sir.
Okay. Next is biological plausibility. Plausibility. What do you mean by plausibility? Let us understand. Atira James, what is plausibility?
So it's like a probable reason, like something happens.
Okay, correct. It is the probability of, again, probability of occurrence. Right? So biological probability is the one where the certain nutrients will definitely influence the growth of certain parts of the body, say where it is directly proven also. It is a biological mechanism. Basically, it is a biological mechanism. It is a clinical risk. To put it very straightforward, there is a clinical risk associated with the nutrient which are very clearly found actually. So biological mechanism underlying the birth defect due to drug use is available. Like for example, now we know that retinoids are required for the vision. So the deficiency of retinoid nutrients can cause the defect in the neuronal crest cell that may affect the vision. So retinoids, we get it from the food what we eat, especially retinoid rich foods. So there is a relationship, right? Folic acid. Folic acid is also nutrient which we get it from the food. And if you don't give folic acid, neuronal tube defect will be seen in the growing fetus. Fallopian tubes, especially, they have to develop properly. Otherwise, deficiency of that leads to the problem, especially the for the growing fetus. Now, folic acid antagonists were found to increase the neuronal tube defect. Folic acid prevented neuronal defect, tube defect. Folic acid antagonist will increase the neuronal tube. It's very clearly found here. So this indicates that certain essential nutrients required for the biological activity of the body needs to be supplied. Otherwise, there is a probable reason that the birth defect uh, will happen. But such kind of relationship is not found for the majority of the drug-induced defect. So that is why one has to be always speculative, doubtful about the risk till the supportive evidence is available. So that is why, as a clinical pharmacist, you have a lot of important role to play in recommending the medicines, especially during the pregnancy and lactation. See, lactation, drug use in lactation is very, very important because two lives are going to be under risk, both mother as well as the child or the infant, suckling infant. So you need to clearly exercise by going through a lot of literatures in order to come to a decision that whether it can be given or whether it should not be given. If it can be given, at what stage it can be given, and what stage it should not be, it should never be given, or throughout the pregnancy should not be given. So such kind of unbiased data availability is in your hand only. So usually what happens is that now you are in the fifth year, probably because of lack of time and all those things. What is that? Whatever the information, readily information which is available in the database, you just get it and try to put it to the practice. But remember, as a clinical pharmacist, you have a lot of role to understand the use of each and every drug in different phases of pregnancy and lactation. So that is where you become different from the doctors in order to recommend. If you want to recommend something, you need to have evidence. Otherwise, no doctor can believe you or trust you on this, because doctors go by the collective experience information, but here you need to go by the evidence-based information. So both are in different directions, but somewhere we need to support the experience of the doctors by giving the evidence. Evidence is only the data where we can give it to the doctors. Right? Any doubt? Manoj is there. Manoj is connected today.
Manoj is absent, sir.
Okay. Kezia, you will have the class test on Tuesday on this
Okay, sir.
chapter. Let me know whether you people want it as a one object MCQ test or part 2, part 1, part 2. Okay. So
Okay,
please
sir.
update me by this week end.
Okay, sir. I will.
And Monday, since we have inspection activities, your seminar is not there. So those who are giving who have planned to give the seminar can give it in the next coming class. Okay, I think Irene and one more was there. Who's the other person?
Jorli.
Huh?
Jorli, sir.
Jarly. Irene and Jarly can plan for the next week. I mean next week in the sense not 9th, say 16th. You can plan your seminar topics. Is okay. So just I'll flip through that. Just go through. We have 5 minutes time. I'll put these notes in your WhatsApp. But the slides is visible. Somebody respond. It is visible. Slide is visible. Okay.
No, sir.
Oh, collapsed. Okay. It is visible now?
Yes, sir.
Okay, go ahead with the reading. We have 5 minutes time to read. Cassia, send me the absentee list.
Okay, sir.
Okay, we are time up now, so you can switch over to next class. Thank you all.